So hello guys. So I already see a few people already joining here. Sorry, I was going in the wrong link. So I was a bit late. So let me see who do I have here. Okay. So hello Anam, Chetna, Dr. Kwara, Dr. Syed Ahmar. Okay, that's how I think I should pronounce it. Indu, Dr. Khalda, Dr. Manikam, Rosina, Tilleen, Vidya. These Vidya, Tilleen is from part 2, right? Vidya, Nigat. Hello everyone. So may I know from here how many are from the part 3? You can just write in the chat box. So how many of you are here for the part 3 examination? Are the most of you from part 2, I guess? Okay. So hello Sarah, iPhone, can you change your name? Okay, like change your name to like your name, not your phone's name. Okay, yeah, Thilin is for part 2. Yes, Rosina is for part 2. This would benefit you guys also because we'll be launching a program for part 2 as well in this. Yeah, hello Anam. Yeah, I was going initially to your that test one link and I was waiting why it's not starting over there. And then finally I saw this link and I joined.
Hello, Dr. Maryada. Welcome. Yeah, we were just waiting for you. Thank you for joining.
Okay, so let's wait for a few more minutes. I think people are still joining and then we can start. Maybe 5
yes,
more minutes. Yeah. So anyone for like part 3 over here in this group who has joined right now?
Me, ma'am.
Okay, so may I know your name, please?
I'm Dr. Monica.
Oh, Monicum. Hello, Dr. Monicum. How have you been?
Fine.
Yeah, am I audible?
Yes, ma'am. You're audible.
Yeah. Okay, so let us wait for like few more minutes. Let's wait a few more people join and then like we can start. So how is the preparation going on, Dr. Monica?
I'm trying my best, ma'am.
Okay. So you're giving exam in this May?
Yeah.
Okay, it's nice. So apart from Dr. Monicum, all that the participants that we have here, are they for part 2? If you're shy to like apart from Dr. Monicum, like all other participants that we have here, are they for like part 2 courses or like some for like part 3 also?
I don't know, ma'am.
Sarah, you are for part 3. Dr. Syed Emmer is for part 3. Thilin for part 2. Okay. MRCPI Anam, Mariam part 3. Okay, so we like plenty of people. I think like it's a nice time we can start because we have a lot of informations to be given today. So hello, namaste, assalamu alaikum to all my dear friends who have joined from different parts of the world. We are here today to practice on the module early pregnancy. So under this, we have specifically said we'll be discussing about the molar pregnancy, but we'll also be doing the templates on how to do this early pregnancy module. And in between, we'll be telling about our different programs that we'll be launching for both part 2 and part 3. And at the end, we are having a very exciting gift surprises for our dear participants. So without wasting much time, let us start. Okay. So before starting, it would be unfair if I do not congratulate you all for the achievements that you have made. Now you're just a step away from getting a prestigious degree of MRCOG. You have already cracked the toughest part of the exam, which is part 2. Part 3, trust me, with utmost dedication, with hard work, persistency, okay, you can get through it. It is not that very difficult. The thing here in part 3 is how good your communication skills are. And trust me, that comes with lot of practice. Like most of us, our primary language is not English. We treat our patient, we see our patient with our native languages. And doing this part 3 is difficult in that terms. But yes, if we practice, if we are persistent, if we are consistent, then it is doable. Okay. So briefly, before going to this early pregnancy module, I think everyone has seen this like 14 modules already, because the same thing we have done in our part 2 as well. And here in part 3 also, from each of the module, we'll be getting one question. So that way we have 14 stations in our examination. Am I clear, guys? You can write in the chat box, okay, your questions and queries. I'll answer them, each of them. And you can also unmute yourself in between and ask any questions if it's not clear to you. So out of this 14 modules, how it is divided is like, we have a 6 simulated patient task, okay? 4 will be with simulated patient task, but with a lay examiner. So mind you guys, this one, SPT with lay examiner, is the one that carries the highest marks, because you have a clinical examiner, you have a lay examiner, and both of them will be giving you the marks. The lay examiner will not give you marks for applied clinical knowledge, but the other 3 domains, whereas a clinical examiner will be given for all the 4 domains. So this is the one with the highest marks, and you will have 4 stations with the lay examiner. And another one is the structured discussion, where there will be 4 structured discussions. So you'll be 6 simulated patient tasks, 4 with lay examiners, and 4. That's how there will be the 14 stations in your examinations. So what I would want to say is, before you start with your role play or your structured discussion, just have a habit of reading the question properly. Okay, if you read the questions before proper, like you are given 2 minutes time, 1 minute, give a thorough read to your question properly, and have in your mind whether it's a simulated patient task, whether it's a SPT with a lay examiner, or whether it is a structured discussion. Because I guess you guys know by now that what all the things are different here. Okay. So with a simulated patient task, you have to say like, okay, if I'm introducing myself, it will be, hello, this is Dr. Malla, one of the doctors in the antenatal clinic today. May I confirm your name and age, please? But if you go to structured discussion, it would be, hello, this is Maryada, one of the exam candidates. I have read the instructions and I'm ready for structured discussion. So things become different from introduction part as well. So if you get fumbled, or if you get confused or nervous you go for a simulated patient task and you prepare as a structured discussion, and then you get fumbling from the beginning, and a shaky starts will lead to a shaky stations, and all the later stations will get hampered. Am I clear on this, guys? Please unmute yourself and speak.
Yes, ma'am.
Okay, yeah. So this is very important, because sometimes what happens is, like, some questions previously, which was given as SPT, they change it into a structured discussion. And we are so much familiar with the question, the name of the patient, the age, the diagnosis she is having. We start doing it as SPT, not realizing it is a structured discussion. Okay. And then it gets like everything gets upside down from there. So what you can do is, even from the examiner, okay, in structured discussion, it will be just the examiner and you. So 2. Okay. For SPT with lay examiner, you will have a clinical examiner, a lay examiner, you will have a role player, and there will be you. So there will be maximum number of people will be in this station. And simulated patient task, there will be clinical examiner, role player, and yourself. I hope this is very clear, because many of the students, they have done this thing completely mistaken in the exams, and that is what had led to the bad results. So this is the basic outline, okay, for I'm talking about this early pregnancy module. So number 1 is introduction. So can I request anyone in the group to do a quick introduction? So if it's a early pregnancy ward, So may I ask if anyone wants to volunteer, well and good, otherwise I'll pick from the participants. Because see, this is part 2, you could just write in the chat box and it would suffice. But here you have to speak, guys. So if you do, the more you speak, the more you break the ice, it will be easier for you. So can I ask, who is there? Dr. Syed Ahmad, to introduce yourself. As in part 3, how would you do that? Come on, just unmute yourself and just a brief introduction. No one is perfect. Everyone is just practicing, okay? So no worries. Or if you want, I can do the introduction myself first, and then you guys can, like note it down and then practice that way. So what do you want? Do you want to do that yourself, or you want me to do how to do the introduction? Because everyone is so quiet and okay, so I think I should ask Dr. Manikam to introduce.
Ma'am, what to
Okay,
tell, ma'am?
he is on duty. Can you do the introduction, like if in any station? So let's say this is an early pregnancy. We are doing that today. So can you introduce
I'm
yourself?
I'm Dr. Monica, Doctor of Early Pregnancy Unit Assessment. Shall I confirm your name and age, please?
Yes, perfect. Very good. So that is how you do the introduction. Okay, it's very easy. So if I have to do for myself, like, hello, I'm Dr. Malla, one of the doctors in the early pregnancy ward today. May I confirm your name and age, please? Okay, so that is how we do the introduction part. So coming to agenda. So agenda setting is basically what brings the patient to your consultation. Okay, so you need to ask the patient. So sometimes there are notes from GP, there are notes from midwife, okay, or sometimes the case notes are provided to you. So you have to see that. So if I have to do introduction and agenda, how do I do? Hello, this is Dr. Malla, one of the doctors in the early pregnancy unit today. May I confirm your name and age, please? Okay, is it okay if I call you Mrs. Smith? Okay, so Mrs. Smith, I gather from your case report that you're here today because of pain in tummy. Is that right? Uh-huh. Okay, surely in the next few minutes, we'll be discussing about your problems in detail and come to a safe and mutually agreeable plan of management to you, or come to a safe plan of management for you. Okay, so that is agenda setting. That is how you do the introduction and agenda. But mind you, if the patient is in pain, she is bleeding, okay, she is in shock, where she needs your prompt attention, you will not be spending so much of time doing this introduction and agenda setting. Okay, at that point of time, how would I have to do? Hello, this is Dr. Malla, one of the doctors in the clinic today. You can say, is this Lisa Joel? Okay, I see you're unwell, Lisa. Would you like me to give you some drugs for vomiting? Okay, then you like quickly start. You do not waste so much of time, because at that time, patient needs your prompt attention. At that time, you have to cut short your introduction and agenda. Okay, or you can like directly say, is it Mrs. Smith? Okay, I see you're unwell today. I'm one of the I'm Dr. Malla, one of the doctors in the clinic today. Would you like me to give some like some medications for vomiting? So that time you have to be prompt. You cannot waste long time saying like this. Can I confirm your name and age, please? Is it okay if I call you this? Okay, I saw your case report. You cannot waste that much of time. So you have to read the question properly, know how the patient is. Okay. And third is the history taking. That is basically the information gathering that we'll be talking in detail later after this slide. So mostly the things that we have in this early pregnancy are this miscarriage, APLA, molar, ectopic. So mostly these are the breaking bad news stations that we have here. And mind you guys, most stations with breaking bad news, these are the stations where there will be the presence of lay examiners, because they want to see your applied clinical knowledge will be checked by the clinical examiner, but they want to see how do you handle such situation, because it's a very sensitive station. So they want you how you sensitively handle those stations. Are you calm? Are you empathetic? Okay, how do you handle these situations? And there are certain things that lay examiners, they want to hear in your station, that I'll come to in later part. Okay, and after that breaking bad news, you will come to the management in a sequential order. Okay, you will tell the patient, you will take patient to the journey of management, and at the end you will close the station. So this is briefly the outline. We'll be doing that in detail. So is there any question you guys want to add? Anything? No voice. Okay. Rakshinda, I think it's like am I audible, guys? You can hear me, right? Yes, okay. So because like no one is making any noise, sometimes I don't know if I'm audible or not. I might just get disconnected. So at least, guys, you have to speak in between. So this is the history. So this is the early pregnancy module template. So most thing that the patient comes with a complaint is pain, vaginal vomit, vaginal bleeding, and vomiting. Okay. So pain, this is Socrates, where we ask the site, onset, characteristics, relieving factor, radiation of pain. Okay. And association of pain, if what is it exacerbated with, and the severity. Okay. So we need to ask in the history, since when she's having the pain, the onset, whether it's an intermittent pain or continuous type of pain, what makes her pain better or worse? Is it radiated to shoulder tip? Is she having a syncopal attack? Okay, is there any associated with vomiting, fever, the changes in the bladder and the bowel habit? Did you take any medications for the pain? So these basically, the easy thing, what I would do for HOPI is start with an open-ended question. Okay. So after you do the introduction, you set an agenda. Okay. And you start with the history. Okay. So you can say, Mrs. Smith, can you tell me about your problems in detail? Then she will tell all about her problems in detail. But if she misses any point in the history, then you can ask. Instead of asking, okay, since when you are having the pain, when did your pain start? Is it intermittent or continuous? So instead of starting with a close-ended question where you will just get a one-line answer, and then that will waste a lot of time. Information gathering you have to do in 2 to 3 minutes time. Okay, the initial 2 to 3 minutes time you have to do the information gathering. So you cannot afford to miss a lot of time over there, but you have to take a lot of information. From there, you will go for your management, right? So start with an open-ended question. Can you tell me about your problems in detail? Or can you tell me about your problems in your own words? So that way the patient will say all the necessary information that you required will be told by the patient herself. But if there's anything that you need to ask, then you can ask, okay? So even in vomit, like vaginal bleeding, the amount, the color, clots, foul smelling, if there's passage of grape-like vesicles, is there fainting episodes, feeling dizzy, okay, for nausea and vomiting, since when she's having that, how frequently she's having that, is it associated with loss of weight, is she tolerating like fluids of any food, any other symptoms like fever, quality of life, is she being able to carry out her day-to-day activities, and was this the same thing in her previous pregnancy as well? Any scan done to see if there's molar pregnancy or the twin pregnancy, okay? And also we have to know about the bowel and the bladder habit. I hope I'm clear till here. Iram, just join. Please give overview about last slides. Last slide means which one, Iram? See, these, I think the live sessions, they will be provided to you guys and you can ask, okay? So which last slide you're talking about? The information gathering. Iram, can you unmute yourself? And I'm all last. Okay, so Iram, like we've already covered few slides dear. So what we'll do is we'll be sharing these live sessions will be shared in the YouTube, and all the this thing will be also uploaded. So you can see that one, okay? Because like a few people have already joined from the beginning. It will be unfair if I start everything from before. But don't worry, we've not come to the role play part, okay? Okay.
Assalamualaikum. Thank you so much, ma'am. Okay, thank you.
Okay, walaikum assalam, dear. Now you also have to know about, so that was the HOPI, history of present illness. The problem with which the patient came with could be the like pain, bleeding, okay, and vomiting. Now her current pregnancy you need to know. Like you can ask, like, may I know more about your pregnancy? Then she will say on herself, okay, well, or if she didn't say, then you can ask, was it a planned pregnancy? Is this your first pregnancy? What is the current duration of the pregnancy? Okay, how is it going so far? Are you regularly taking your folic acid? You can ask blood group here, you can ask later also, okay? And has she been booked to midwife or not, depending on her duration of pregnancy. Her dating scans, labs, down screenings, spontaneous conceptions are assisted. So it depends on the stations, okay? You do not ask this in each and every station, but even in early pregnancy, you know, depending on which duration of pregnancy is, we do ask the question. And then if it's an obstetric history, we have to ask how about her, how her previous pregnancies were, and the mode of delivery, and how was her recovery in the postpartum period. Okay. Coming to the gynecology, we ask the cervical screening. Don't ask cervical smear. Before it was the cervical smear, but now as we do the HPV testing, we ask, are you up to date with the cervical screening? And see, don't ask it for less than 25 years. Okay. Those who are like 19, 21 also, like just you are practicing, just because you are practicing that thing to ask to every patient, mind the age of the patient. If she's above 25 years, then ask, are you up to date with your cervical screening? Okay. And then the medical history, are you generally fit and well? Okay. Then family history, is there any disease running in the family? Fine. Surgical, have you had any previous history of surgery? Or if she said like before she had a cesarean section, at that time also you can ask, okay, any other surgeries apart from cesarean section? In obstetric, you can ask that time, so that you know, like you will buy time that way. You won't waste a lot of time. And then the drug and allergies. So as I said, like when the patient initially is in pain or vomiting and you are offering her medications, okay? Hello, Jazz, I see you are unwell. Would you like me to give some medications for vomiting? Any allergies to any medication? You are done there. You don't need to again ask about drug and allergy history later. Okay, it's done if you have asked it early. Then you'll ask about the personal history. May I know your BMI? Do you smoke, drink? Pardon me, asking any recreational drugs? Okay, that's how you ask about smoke, alcohol, drugs. And about sexually shared infection, I have kept these 3 asterisks because you need to signpost. You cannot just ask, may I know if you ever have, or if you or your partner has been ever treated for sexually shared infections? You fail then and there if it's lay examiner, because that is very insensitive. You ask that way. Okay, for sexually shared infection, you have to say, Jazz, there are a few questions that I would like to know about you, which might sound quite intrusive, but it is important for your management. Okay. Then you ask, have you and your partner ever been treated for sexually shared infection? So if you like the way that I'm asking, you can also write it down in your note, okay? Because this is how it should be done for the sexually shared infections, or any of the thing that you feel the patient would feel offended on asking, you can signpost. But for smoking and alcohol, we generally said, I would like to know some personal habit. Do you smoke? Do alcohol? Pardon me asking recreational drugs. Okay. For sexually shared infection, do signposting. Do not ask any questions on sexually shared infections or any of these topics without signposting. And then social history is, whom do we live with? How is the support at home? So don't say husband, okay? On the Western, this is the UK's examination. So in the Western part, people live together even without getting married. It's not necessary they're husband and wife, they are partners. So be at the safer side and say, how is the support at home? Is your partner supportive? Okay, if she's saying I'm living with my partner, then say, is he supportive or is your partner supportive? And then the mental health, how have you been in the past 4 weeks? So is it clear? So this is basically the general template for everything, but I have kept more points on early pregnancy because that is what we will be dealing with. So if there's any confusion, guys, you can ask me. No confusion, everyone is very clear. Ma'am, what is the importance of STD in this smaller pregnancy? No, dear, I'm not telling of this smaller pregnancy over here, but this is the basic general template. Okay, this is the general template, Amal, for the early pregnancy. And then we have come with the breaking bad news. Okay. You're welcome, dear. So breaking bad news, as I said, this is a lot of breaking bad news station. There's ectopic, there's recurrent pregnancy loss, molar, APLA. So there'll be this breaking bad news. So you have to do that very empathetically, okay? And then coming to the management, okay? So it will depend upon the cause. So what if it's ectopic, you will take the management accordingly. If it's molar, accordingly. So you have to do that. You have to address the patient's concern and then you close. So how do you do the closure? Number one, if you're admitting the patient, you'll say, okay, till the time I'm right here, Jazz, doing the require documentation for your admission. Till then, you can have a look at the information leaflet. I've already informed my consultant, okay? Or if you're arranging the patient for follow-up, you can say that, okay, thank you for giving me the time. I'll arrange the next follow-up with my consultant. This is the information leaflet. If there is any of the red flag signs, you will tell, okay, like if there's bleeding, if you feel dizzy, if there's pain, then this is the 24/7 hospital contact number. You can contact. Okay, thank you for letting me help you. And that way, okay, be thankful to the patient. Okay. Okay. So now we are coming to the first station here.
Excuse me, ma'am. Ma'am, is PUL BBN, ma'am?
So the pregnancy of unknown location, right?
Yes,
I wouldn't say it's a big BBN, but it is a mini BBN because the patient is pregnant. We do not know where it is located, right? So it could be intrauterine. Okay, it could not be. So here we will do a mini BBN, but not a very big BBN.
Okay,
Yeah?
thank you, ma'am.
You're welcome, yeah. So now this is a SPT with lay examiner, and marks will be awarded for patient safety, information gathering, communication with patients and relatives, applied clinical knowledge. So we know this is not a structured discussion. This is a SPT with lay examiner. That thing we have to keep in mind. Okay, number 1 point. Second point, so this is the question, okay? Okay, so I had the thumbnail. So you are ST5 in early pregnancy ward. Nurse on duty has called you to see Mrs. Phillip, 26 years, who is in her first pregnancy of 7 weeks. She has been bleeding heavily since morning, passing vesicles, having excessive vomiting. The report of ultrasound has been provided to you. So you have 10 minutes in which you have to take history, explain the diagnosis, and provide the management. So just in 1 minute, you read the questions. So firstly, it is SPT with lay examiner. Second, this is the candidate instruction. You have been given all the investigations and the ultrasound. Okay, so now you start with the module. Okay, so after 2 minutes, your time will start. For 10 minutes, you have to take the information gathering from the patient, communicate with colleagues, communication with patients and relatives. You have to do the applied clinical knowledge, okay, and the patient safety. So that comes here because that is the domain you are being tested for, right? 1, 2, 3, 4 domains you are being tested for, and that you have to do in the 10 minutes. So if you have to do the introduction, apart from Dr. Manikam, anyone else can do that because like she did it. I have done twice. Okay, so I think you can, like anyone who is giving part 3 can just unmute themselves and do the introduction. Don't worry, we'll be doing the role play. And if you guys are so shy, I'll be doing that, no worries. But like at least you should learn how to do introduction agenda from this station. Okay. Dr. Mavish, can you do that? I think you're unmuted for yourself.
Hello.
Or shall I ask Oz?
Here. Okay.
Who's speaking? Yeah. So can you introduce yourself? Hello.
Hello, I'm Dr. Osatirio in this telepregnancy unit. Today, may I confirm your name and age, please?
Hello, doctor. I'm Monica James.
Okay, I can see from your. Okay.
That's good. Okay. Yeah. So that is how you do the introduction. And so once I say my name, then you'll ask me, how would you like me to call you? Or is it okay if I call you Mrs. James or Monica? Okay, Oz?
Yeah.
Okay. So introduction is done. So agenda setting. Okay, that I'll give you with a candidate instruction. So information gathering, BBN, afford support, management of here, we have to see the patient is vomiting. I think I did a little early with this. Here, if you've not seen, you see the thing investigations properly, okay? She is dehydrated, okay? And she has this ketone. So you also have to treat her for hyperemesis gravidarum. Just don't keep you in your head molar pregnancy and you completely ignore the fact she also has hyperemesis gravidarum. Here simultaneously, you have to manage 2 things. You tell her the future plan and give the information leaflet at the end. So what the examiners are looking for, how you do the introduction. It has to be a very confident introduction. It has to be very clear, okay? No need to be unnecessarily very loud, but it has to be clear and audible, right? How you build rapport with the role player. Are you calm, soft, and empathetic? Okay, have you settled the patient complaint and acknowledged her concern? How did you do the breaking bad news? Did you explain the situation in sequence? Did it go sequentially or not? Like you are doing information gathering and then you are giving the information same time. Then again, you are doing information gathering. Okay, that way it doesn't work, because then you start being like, you will overdo your time. You will not get the necessary information from the patient, and you will not be able to give the required information to the patient as well. And you will also fumble in the applied clinical knowledge as well as patient safety. So it has to go in sequence. The only way it can go is the more you practice, it comes with practice. Okay. And avoid medical jargon. So this is an SPT with medical, the lay examiner or the SPT. You cannot use medical jargons. Okay. You cannot say uterus, amniotic fluid, like that. Okay, you have to say womb fluid or water around the baby. So you have to change the medical jargons to the lay terminologies. So we have already discussed the information gathering part. Now the patient safety. Patient safety, have you assessed the patient's concern and ideas? Have you been able to offer the support to the patient? Did we stabilize and hydrate the patient? Okay, because she has dehydration, she's vomiting like anything. So did we stabilize her, or we were just busy gathering the information and giving it, neglecting the fact that she is dehydrated, she is vomiting, she is unwell? Okay. And have we said like the review will be done by consultant? Okay, because this needs to be seen by the consultant. And have we said suction and evacuation as the preferred management or not? Did we mention the GTD center, that you will be registered in GTD center where you will have the follow-up? And a very important point for Molar is the follow-up and the recurrence. So these all should be included in the station. Am I clear? So is everyone sleeping, or am I offline? Like nobody's replying?
You're clear, ma'am.
Okay, so it's only Manikam and I think Oza and Iram, they were still like unmuting themselves and speaking. Aman is just typing, yes, ma'am. Shaina's clear. Tinin, we are listening. How would I know, dear, that you are listening? You might just be sleeping, right? Kalda said clear. Okay. See, I said there is a gift at the end of the session, guys. So better be more like proactive, okay? Everybody's not getting the gift. Yeah, Mariam says yes now. Okay. So I should know I'm like teaching students, not talking to myself. Okay. Yeah, so coming to this applied clinical management. So those who have given exams in January batch, I think they're still fresh with their knowledge. What they can do at most is like just go through their notes and they're done. Okay. For those who have given previously, maybe they again have to go to GTGs, talk articles, SIPs, okay, and nice guidelines, because things have changed. Certain things have updated. So that the good thing to do with the part 3 examination is as soon as you clear part 2, just book your exam and give part 3, because you get updated with your knowledge, and this applied clinical knowledge, it helps in this applied clinical knowledge a lot. Okay. So here, what do we do in applied clinical knowledge means, have you mentioned that you will be giving fluid to the patient? Okay. You will be avoiding glucose. You'll be giving antiemetics, thiamine. Okay. You won't say we give you antiemetics, we'll give you thiamine, we'll give you crystalloid. Okay. We'll give you fluid, we'll give you medication to stop vomiting, we'll give you vitamins. Okay. So that you have to, you have to avoid the medical jargon. And preoperatively, have you said like you'll be taking the consent, you will do the blood arrangement, assessment with anesthesiologist. You will avoid prolonged cervical preparation. In the operation, it will be the first case on the surgical list. Okay. The WHO checklist will be checked. It will be done by consultant. Okay. You will avoid oxytocin except in the case of torrential hemorrhage. This will be done under scan guidance. And after the sample is obtained, you will correctly label it and send for HPE. So these are the applied clinical knowledge. So this also comes in the patient safety, okay, that you have labeled it correctly and sent for HPE. Okay, guys. So post-operatively, if the patient is blood group negative, you will give anti-D, you will register the patient in GTT center, you will connect her in the contraception clinic because she has to avoid pregnancy. The best is the barrier method, though in your guideline they say you can use oral contraceptive pills, but it's better to avoid that till the beta HCG is normal. We do not give anything intrauterine. Okay, the red flag sign that we need to explain the patient is if she has any bleeding, difficulty in breathing, or any abnormal body movement, okay, the neurological signs, then you have to come see us. This is our 24/7 hospital contact number, and also mention the recurrence. So these are a must in your station that you have to mention. Okay. Okay, Dr. Sayed, you are in duty. Good that you are listening. So if there's any questions still now, you guys can like unmute yourself or type. It's better you unmute yourself and ask questions, okay? You have to break the ice. You cannot be shy for part 3. You have to speak up. So if there's anything, otherwise we go towards the role play.
So sorry, are we going to talk on maybe if there's vaginal bleeding and the role of oxytocin, and also the gray area of cervical preparation, probably if you want to do a suction evacuation.
Yeah, so yes, we have to say that these are the patient safety points. So we will explain the patient that we will give you, since what we say that to the patient is we will give you some medications only if there is excessive, if you're increased bleeding or excessive bleeding. We will not say oxytocin, will not say cervical preparation to her, but some medications we'll be giving you shortly before starting the procedure. Okay, we can say that. No, why is the need for incident reporting and datics in your Aman? It's not required in this station, okay? So, okay, so this is the candidate instruction, this is the same questions, okay? So ST5 in early pregnancy ward, nurse in duty has called you. So I'll show how this is to be done because I don't see anyone like actively participating. It's okay. At least like learn like how it is to be done from here, okay? So read the questions. And if you're done with the question, we'll start with the role play. So once you're done with the question, like reading the question, just give thumbs up or whatever thing in the chat that you have read the question so that I can start with my role play. Okay, Nikat has given a thumbs up. She's done reading the question. So you don't get so many time to read the question, it's just 2 minutes. So I think I start, okay? Hello, I'm Dr. Malla, one of the doctors in the early pregnancy ward today. Are you Jazz Phillips? Yes, doctor. Jazz, I see you're unwell. Would you like me to give some medicines for vomiting? Do you have any allergies to any drugs? Yes, doctor, please give me some medicines. I can't stop throwing up. I don't remember I've had any allergy to any medicines till date. Okay, okay, Jazz, I'd also ask the nurse to give you some fluid from vein to maintain your hydration. Is that okay? Yes, doctor. Wait for a few seconds and may I continue? You're sure, doctor. So when there is this patient, you are giving medication, you are stabilizing the patient, and you have given her some like oxygen or pain medication or fluid. At that time, just wait for 2 or 3 seconds. Okay, just don't jump into like asking questions. Let her give some time that she is settled, and then you ask her permission to start. Like you can say, like, can you talk to me now? Or may I continue? Okay, is it okay? Now can you talk, Jazz? Okay, so do that thing. Okay, is it clear? So Jazz, can you tell me more about your problems in detail? So this is the open-ended question. So when I ask this, the patient comes with the information that I need. Doctor, I have been having bleeding since 2 days. Initially, it was just spotting, bright red in color, but from last night, it has drastically increased. It's soaking 4 to 5 pads a day. And with this, I feel there's big chunk of clots coming down and some bubble-like things coming down. Okay, I'm sorry that you're going through all this, Jazz, but don't worry, we're here to help you. Do you also feel dizzy, Jazz? No, not really, doctor, but I have this vomiting since 1 week and I throw up like anything. I can't even drink water. Even the sight and smell of food makes me sick. Okay, Jazz, have you tried any medications for your vomiting? No, doctor, I've not tried any medications yet. Jazz, is there any problem with like fever, problem with waterworks, bowel problem, or pain in tummy? No, no, doctor, no such things. Okay, Jazz, I see from your case report that this is your first pregnancy, right? Yes, doctor, this is my very first pregnancy. Are you up to date with your cervical screening? Yes, doctor. Are you generally fit and well? Yes, doctor, I'm usually a very healthy person. Have you had any surgeries before? No, doctor, no surgeries. May I know your blood group, Jazz? It's B negative, doctor. Okay, do you have any transfusion before or any reservations to transfusion if required? No, doctor, no reservations. May I know your BMI, Jazz? I think last time I checked, it must be 24, doctor. Okay, so Jazz, do you smoke, drink, or pardon me asking, any recreational drugs? No, doctor, I don't do anything. Okay, so Jazz, whom do you live with? I live with my partner, doctor. And is he supportive? He's quite supportive. Okay, so thank you for giving me all the information, Jazz. Is there anything you'd want to add? So this last line that I said, is there anything you'd want to add? It's a lifesaver. So even if something that I've missed out on asking, because in exam time, you are under stress, you are nervous, you might have done some stations wrong, so you might not be able to concentrate on asking questions. So it's very natural that you may miss one or other questions, okay? It's not very out of the box that you missed a question. But if you say, is there anything you would want to add, then the role player will say, maybe I forgot to ask blood group in this question. Then say, doctor, my blood group is B negative, if that is of any importance to you. Then you say, oh, thank you so much, Jazz. You don't say, oh, thank you, Jazz, I had forgot asking that question. Don't say that. Don't mention you forgot or whatever that word. But at that end, always after doing the information gathering, you should ask, is there anything you would want to add? Or is there anything, Jazz? Okay, always you have that question, that will be a lifesaver, because the role player, they will be given the instructions, okay, to say all those things. But if you have not asked that, then she will help you in answering that question. Okay, is that clear? So write it down. That is the after information gathering, you said, is there anything you would want to add? Okay, so can I be your role player? Oh, I've already started. We can do that in structured discussion. So I see you're alone, Jazz. Would you like me to call anyone, as I have some concerning news? Okay, so it's a Breaking Bad news. So you will say, I see you're alone here. Would you like to be with someone? Because I have a concerning news for you. Okay, at that time, patient will say like, doctor, like nobody can come at the moment. Whatever news there is, you can give it to me. Okay. So then you start with, Jazz, I've provided with your report. I've confirmed your name and your NHS number. This is patient safety. If you forget to tell this, maybe you've seen some others report and you are telling it to Jazz. Okay. So you have to say, your reports have been provided with me, Jazz, and I've confirmed your name and NHS number. The report belongs to you. And then you start explaining. Okay. Normally in pregnancy, the sperm containing a thread-like structure called chromosome meets with an egg that contains chromosome, which leads to normal pregnancy. But in few cases, sperm meets an empty egg that doesn't contain the chromosome. It will lead to abnormal pregnancy. That in no way will lead to live birth and healthy baby. This type of pregnancy we term as molar pregnancy. And I'm sorry to be bearer of this news, Jazz, but you have molar pregnancy. Okay, and give few seconds for her to sulk that news. Then she will say, no, doctor, this can't be true. Is there no medication, any surgeries that can correct this, or this cannot be true? Like she will be in denial. Okay, then you have to be very calm. I do understand that this news might have come as a shock to you, Jazz, but I want you to understand there are no chances that this could lead to a formation of a baby. So there's an empty egg and a sperm. So in no way, if you continue this, there will be no formation of a baby. You have to be very firm with that thing. Okay. And then you also have to say, like, continuing this pregnancy, it would cause heavy bleeding, passage of grape-like structures, excessive vomiting, problems in your thyroid, rise of blood pressure with loss of protein in urine before 20 weeks. I'm sorry to tell you, Jazz, but this pregnancy should be ended. Okay. So you have to be very clear that you cannot continue this pregnancy, but you cannot say, no, you cannot continue this pregnancy. What you are talking about? You cannot say that thing to her very rudely. One thing is there's a lay examiner, and that second thing is that is not how you speak. Okay. There. So you have to say it in a manner that she understands, like why she cannot continue this pregnancy, because at any cost, that thing is not going to turn into a fetus inside. Secondly, if she keeps continuing it, then she will have so and so health problems. So that's what you need to keep her in her mind. Okay, then she will understand it. Okay, doc, because the role players are instructed in such a way that after you have explained this thing, then they won't be arguing with you more. So, okay, doctor, I get your point. What further should I do? First of all, Jazz, I need to admit you will be under the joint team care comprising of my consultant, blood doctor, anesthetist, specialist nurse. We will continue giving medicines, fluids, vitamins for your vomiting. We will send some tests in blood, which will also include the pregnancy hormone test, which we call as beta-HCG. We will group and save your blood. Are you with me, Jazz? Yes. So I said there are some words that your lay examiner, they want to listen. Okay. So that is, are you following me? Are you with me? Do you have any questions? Have I addressed your concerns? So these four things, or you can choose anything. Always don't say, are you with me? Are you with me? Are you with me? It becomes very monotonous. And like the thing is like, even you don't want to hear that. So are you with me, Jazz? Are you getting my point? Okay. Did you understand? Have I addressed your concerns and queries? So have that thing 5 sentences in your practice in a lay examiner station. Also in SPT, you need that, but more in lay examiner. Okay. Am I clear? Hello, 33 participants. Are you sleeping?
You're clear, ma'am.
Clear.
Okay. So I think this Oz and Manikam, they are getting something at the end. Apart from that, I don't think there's anyone interested in getting anything. Okay. So where was I? So then you'll say that after we obtain an informed consent, we'll plan for surgical removal of this pregnancy. It will be performed by my consultant on the scan, and the tissue which will be obtained, we'll label it correctly and we'll send for the HB testing. Am I clear, Jazz? Yes, doctor. Okay, so here I've given her chunk of information first, and then I've asked, am I clear? Are you with me? Okay, so that is the thing that the lay examiner is interested in. He wouldn't be knowing what is the HP, scan guidance, suction removal. He wouldn't be understanding that, but these points he will be marking you for. And that we will be monitoring your pulse, your blood pressure, if there's any risk of formation of clot in limb and lung. We will also have to register you in the GTD center. Any questions so far, Jazz? No, doctor. You an injection called anti-D. Am I audible? It says your internet connection is unstable. So I'm audible, right?
Yes, ma'am.
Yeah, thank you. So we also have to offer you an injection called anti-D because your blood group is negative. This is to prevent any adverse effect in your next pregnancy, Jazz. We also would like you to connect to the contraceptive clinic for you to use a suitable method of contraception, like a barrier method or pills, but we generally avoid coil in the womb. Why do I have to use contraception, doctor? She can ask that question, right? So, as you have to avoid pregnancy till your pregnancy hormone test or beta-HCG, you can say anything, comes normal, Jazz. You have to follow up with your beta-HCG at GTG center for 6 months from evacuation. If the beta-HCG returns normal within 56 days or 6 months from when the hormone came normal, is it okay? Yes, doctor. Whenever you feel unwell, there's increased bleeding, breathing problem, abnormal body movement, you have to come see us in our hospital. This is the 24/7 contact number. Thank you, doctor. I have one question. Okay, she's asking a question. Yes, go ahead. Will I have normal pregnancy later? Okay, So yes, Jazz, certainly 99 out of 100 women will have normal pregnancy, whereas it can reoccur in 1 out of 100 pregnancies. Is there any other questions, Jazz? No, doctor. Okay, so I'm right here making an arrangement for your admission. I have informed my consultant he will be here any moment. Till then, please go through this information leaflet. Thank you for letting me help you, Jazz. Thank you, doctor. So this is how a station should end. Okay, so you're like maybe like in the questions like this, the examiner, sorry, the role player is helping. Okay, so she's asking the question herself, like, will I have a normal pregnancy later? Because like about recurrence, the doctor was not saying anything. Okay, so will I have normal pregnancy later? And then the examiner, the student remembers. Okay, now I have to ask about the recurrence. So yes, out of 99 out of 100, you will have normal pregnancy, but it can recur in 1 out of 100. So 1% is the recurrence. So that is how we say, we don't say percentage wise. Okay, you will say 1 out of 100 or 99 out of 100. Okay, which convert the percentage into this language form. So this is how it is done. This is how the role player will also help you and guide you if you forget some things. Okay, so from beginning to end, is there any question in this role play? You can write your own words, you can have your own thing in between, no problem. But I want you guys to have like a proper introduction and the ending, okay? That you don't change because it's almost the same for most of the thing. The most important thing in introduction is the situational awareness. You should know where you are. You cannot always like 14 stations here, you know today that we are doing the molar pregnancy and that is the early pregnancy ward unit clinic we will be, okay? But in examination, you don't know what next station is coming, right? So if it's a general gynecology, you say, hello, this is Dr. Malla, one of the doctors in the gynecology clinic today. Okay. Hello, this is Dr. Malla, one of the doctors in the antenatal clinic today. So only that thing changes. The other thing remains the same. Don't make a very high-fi thing that you stop, like you have to remember those introduction. It should come very promptly. It should be in the tip of your tongue. Okay. And if you keep on practicing, even this information gathering, you should know like what to ask the next. So you have to practice like it's like less like around 1.5 months left for your exam, right? Part 3, those who are giving in May. So you have to practice at least like 10 stations a day. It has to come very like you should know what thing you're going to ask next. You should not be thinking if you keep on doing that, one thing your time will go, second thing the examiner starts becoming irritated from you, third thing the role player won't help you. Okay. So any questions here? Okay. So Nigat is also being active here in the chat. So Oz, Monikam, any question?
Follow up, ma'am.
No?
Ma'am.
I hope it was clear because I was like
Yes,
doing
ma'am.
properly role play. I was
It's clear.
It's clear, ma'am.
I was speaking in between what you guys should not miss in the examination. Okay, like part 3, it's like you have to get a proper right guidance. Okay, and it's doable in 1 month or so. So
And,
before we proceed to structured discussion, okay, this is a very, very, very important announcement that I'm making. So we are launching this MRCOG 3 booster course. Okay, so I guess you guys must have seen the ads of this in the Facebook, Telegrams, like WhatsApp, whichever medium you were using, and might be wondering what this actually is. So what we thought was, do some recall station, like the recent recalls that we had in the exams of November and February 2023 students. We have collected the recalls. And we thought like, why not do these 14 modules in 10 days of extreme focus? It will be, we will be covering all the 14 modules in that 10 days, okay? And we thought like have a listener as well as the active candidates. So the seat for the active candidate is very limited because we want the active candidates to have a one-to-one speak up, okay, for the stations with us. So like we're sorry for that. For the active candidates, the seats are very limited. So book as fast as possible so that you get the chance to perform in each and every stations, because in exams you will be doing 14 stations, right? So if you get the chance to speak all the 14 stations, well and good. But even if you don't get the chance to be the active participant, even being a listener, like I guess for this, I made all of you a listener, and I hope you guys learned a lot also, right? Even though you were just listening, none of you are actively participating. I was being the role player. I was being the exam candidate, both by myself. And even from listening, you can learn a lot, like what points you should add, what points you should not miss, what things you can like ignore in a station. That is very important to know. So that's what we did. So this is a very important announcement for Part 3 students. It's a booster course. Okay, all the 14 modules will be doing, and we have all this from the recalls. Okay, so regarding this, if there is anything you would want to know in detail, okay, about this courses, so we have our backend team. You can connect with them. Okay, they will tell you about these courses in detail, and we are starting this in April. And like most of the students here are from my Part 2 group as well. Okay, so I'm also doing this progressive course again because it was a huge success in the last session of January. I had started on taking November, December, and the exam was like mid of November and January. So the exam was in January, and they were very happy with the course, and the results were like outstanding. So this is, again, we are starting with this 2 months of scheduled Telegram discussion. It will be daily classes, no break in between, because we are doing this 4 to 6 months courses in squeezing in 2 months. So it's a very intensive course. So we have 2 phases. One is preparation, then again, we have revision here. Okay, so in the revision courses, we'll do the free exam recalls workshop also. There will be topic tests given. So this is a 2-month dedicated plan with me. You'll also be getting an access to the website portals. So if any questions on this progressive course also, you can ask me, you can ask like any backend team. Okay, so is it clear about 2 courses that we're launching?
Yes, ma'am.
Okay.
That's wonderful.
Oh, yes, ma'am.
Yeah.
Okay, so now let's go to this structured discussion. So Oz, you want to do this structured discussion?
Ma'am,
Or you
shall I,
want to
ma'am?
be a listener?
Shall I, ma'am?
Okay, let's do like I think we have 4 questions here. So let's like one will be Oz, one will be Manikam, 2 others, and we'll just do it. And then at the end, I'll also again we'll say how it should be done. Okay, just a very practice. Yeah, this is not the final examination. So just be very cool and calm. Okay, just like you can treat me as your friend, and just we are talking the discussion. So who do I choose? Dr. Ahmad is in duty. So Nigat, you are for Part 2 or 3, dear? Or if no one is, who was for Part 3? Let me see. Okay, Mariam.
Yes, ma'am.
Do you want to volunteer? Do you want to volunteer?
Yes, ma'am, I can
It's
try.
okay. Okay, I'll at the end. Okay, so anyway, at the end, I'll tell you how it should be done. If you do it well and good, that's like I don't have to speak. So one more. Okay, one more. Actually, guys, in this free session, you are getting chance to speak up, and like no one is ready. So I don't see anyone here. 2 messages. So Nigat is for Part 2. I should not ask her. So, okay, one of you will get the chance to do it twice. Okay, so who wants to go first? I would like to, ma'am, because our the Part 2 contains both. Okay, so one we have Thileen. Is that the right way that I'm pronouncing your name?
Thilini, madam.
Thileen. Okay, so where are you from, Thileen?
Sri Lanka.
Sri Lanka. Okay. Okay. So nice. I think it's the first time I'm having a student from Sri Lanka. So you're giving exam for part 2?
Yes, ma'am. Both. I'm planning to sit for both MRCOG Part 2 plus MD Part 2 in the country.
Okay, fine. So we have 4. We have Dr. Manikam, we have Mariam, we have Oz, and we have Thinali. So who wants to go first? Just say me. Who wants to go first? I choose.
Me, ma'am.
Shall I, ma'am?
Okay, Dr. Manikam. So let's start. Okay, let's see. That Dr. Manikam will be first, Oz will be second, Mariam will be third, Thinali will be fourth question. Okay.
Okay.
We will follow that. Okay, so that we don't have to ask after each question who's going. So let me start. So read this question. This is a structured discussions. Marks will be awarded for patient safety, communications with colleagues, applied clinical knowledge. So your time starts. I should have kept a timer. Just a second. Manikam, you are the first one. After you are done, you can say like, I'm done and I'm ready, so that we start. Okay? Because I didn't keep a timer. You can also read the question aloud so that like everyone who is even sleeping, they should like
You're
come.
an ST5 who will discuss the case of Mrs. Clara Smith, 30 years lady, but miscarriage. She had undergone evacuation, has been 3 weeks past treatment, but she has got vaginal bleeding. Upon doing urine pregnancy test yesterday, it was positive. She's a known case of idiopathic thrombocytopenic purpura. She had undergone platelet transfusion at the time of the management of the miscarriage, as her platelets were low. And now you meet your examiner to discuss your patient. Shall I start?
Okay, can we start?
I am Monica, one of the exam candidates. I've gone through the scenario. I'm ready for the structured discussion. She's a 30-year-old lady who had undergone the surgical treatment for the missed miscarriage three weeks before. And now she has come with urine pregnancy test with the bleeding. And she was being transfused with the platelets during that time, as she is having a condition called idiopathic thrombocytopenic purpura. So she's having a recurrent bleeding after the treatment for missed miscarriage. So we have to ask history from the patient. I have to ask the patient about the history after greeting her and introducing myself with the name and post. Then I'll ask her about how it happened, to tell about what happened in her own words. Then I'll ask about the duration of the pregnancy, what it happened, did she had passed any vesicles, and whether she was treated with whether the products of conception have been sent for any histopathological examination, and whether she and her blood group, her allergies, and whether she has been previously pregnant, and also ask about her whether medical conditions and what she has been what was the treatment she has had for the idiopathic thrombocytopenic purpura, whether she has had any previous history of bruises or any bleeding, and whether she is on steroids, and then I'll ask about any risk for any reservation against transfusion and her blood group and her support. Then I'll ask now as if whether she's having any pain now or any burning while peeing, like that, and any fever. After that, with her consent in presence of chaplain, I will examine her for examination for any pallor, and I will examine her abdomen for whether the uterus is palpable or enlarged, whether there is any tenderness. Then I'll the specialist nurse will do the examination of the blood pressure, heart rate, and temperature. Then I will do a speculum examination and to see for any presence of any vesicles. Then if the patient is consenting, I'll do an internal examination to palpate for the size of the uterus and any tenderness. Then I will ask her for further. I will come to a conclusion regarding according to the findings, ma'am. What are the findings? Shall I know the findings, ma'am? Examination findings. Ma'am, am I audible, ma'am?
Hello.
Ma'am, shall I get the findings, ma'am? Any examination findings?
Okay, her vitals are stable. Per abdomen, she has no guarding rigidity. Okay, and there are no per vaginum, there is no cervical tenderness.
So then I'll offer her transvaginal ultrasound scan, and as the urine pregnancy test is already positive, we'll go for a beta HCG measurement also. Then as she has got so much of bleeding, also look for a full blood count, whether the platelets have gone down and whether she's anemic to find out that. And I'll look at the transvaginal scan for any retained products of conception or any molar pregnancy, and the beta HCG to see whether the levels are very high. Okay, ma'am. Then I will inform my consultant about this patient.
Okay, so if this is the only question you have, how do you end it?
This is the only question, ma'am.
No, like we have 4 students who are volunteering.
Okay,
so
okay,
if this
ma'am.
is the only
Ma'am,
question,
please, ma'am. Okay, ma'am. So sorry, ma'am. I have forgotten. As if I am presenting, I am going on asking you. Okay, ma'am. I'll stop with this.
Yeah. So how
Thank
do
you,
you
ma'am.
end it, Monica?
Uh,
You say something to the examiner at the end?
Okay. So I will treat the patient according to the reports, and I will inform my consultant, and I will give the patient information leaflet so that she'll be going through, and then I'll write back to her GP, and I'll document everything, and I will inform my consultant so that she will come and examine. And thank you, sir. Is it okay, ma'am? Ma'am, am I audible? Ma'am, am I audible, ma'am?
Yes.
Okay, thank you, ma'am.
Yeah, sorry for the disruption. We are having this heavy rainfall, so the internet connection is quite unstable. Sorry for the disruption. Okay, so yes, I was asking Manikam, how do you end the session? So supposing this is your last question, you've done all. So at the end, you have to thank the examiner. Okay. So first, your introduction was very good, to the point. You said, "Hello, I'm Manikam, one of the exam candidates. I have read the instruction and I'm ready for structured discussion." Bang on, you've said that very well. And also the history taking part was very good. You like asked almost everything, like from taking steroid, like from the HOPI, taking steroids, and the past history of, or like bruises for ITP. You have covered both. Okay, so for the molar as well as ITP, you've covered both, and also said you'll examine in presence of a chaperone, and also you said the investigation. So guys, if there is any question on initial assessment of the patient, make sure you are asking about the history. You are asking about the history. You are performing an examination, and you are sending the investigation. That is very important. So all this will only cover the initial assessment. Just taking history or the examination won't suffice. Okay, so history, examination, investigations, and once it is done, so like general, there'll be 4-5 questions. But since she's the taking this first question at the end, how do you end? Like, thank you for your time. Thank you so much for your time. Okay, is it clear?
Okay, ma'am. Okay, ma'am.
Yeah. So well done, Manikam. That was very good. Yeah. So who's taking the next question? I think the next I will give to Thingili, and the fourth one I'll give to Oz, okay? Because that is a little bit tough one. So Thingli, can you do the second one? Please do, like all the other 3 participants, do the introduction, okay? Then answer the question, and at the end say thank you. That has to be the habit. That should come promptly. Okay? So next question. Thingli, are you there?
Yes, ma'am.
Okay, so what are the risks in your patient? So Monikam, I want to tell one point. Like, I was about to ask you the question, but you just read the question and you jumped into answering. So sometimes the examiner, they just like show you the questions, but sometimes like most of them, they do ask the questions. So just have the patience to wait a little bit after you introduce
Okay.
yourself.
Okay, ma'am.
So here is the exam question. Okay. Yeah.
Okay.
So apart from that, it was bang on. It was very nice. So
Thank you.
Thingli, what are the risks in your patient?
Okay, so in this patient, she's coming back after a medical management for
You have to
miscarriage.
introduce yourself, dear.
Okay.
You need to introduce yourself.
I'm Tilini, one of the doctors from the
No, one
pregnancy
of the
clinic
exam candidates.
candidates.
So you are talking with the examiner. There is no role player. Okay, you're not talking with the patient. So hello, I'm Dr. Thinili, one of the exam candidates. I've read the instructions and I'm ready for structured discussion. Just write it on top of the notebook or whatever, though you are like part 2 student. Okay, for rest of the people who are giving part 3, this should be your introduction. Yeah, just start.
Hello, I'm Dr. Tilini, one of the candidates for the part 2 examination. And I have read the instructions and I'm ready for the questions.
Okay, so what are the risks in your patient?
In this patient, she has been managed with medical management for a miscarriage and coming back after 3 weeks with a positive urine pregnancy and bleeding per vaginum. So I would classify the problems with the cause of the situation. So probably this could be either a retained product of conception or a gestational trophoblastic disease. So if I take retained products of conception, the risks are due to infection. She could go into sepsis and complicated, if not treated promptly, could lead to death even. And other thing is, if she's having gestational trophoblastic disease, the complication, the risks are she could, due to heavy bleeding, she could go into anemic complications, heart failure. and she could have preeclampsia, she could have thyrotoxicosis, and the complications such as hyperemesis leading to dehydration, and also in the management of this patient, because she might need surgical evacuation with the bogginess of the uterus, she could have uterine perforations. And also, if there's torrential bleeding, we might need to manage with oxytocin, which could lead to embolism of the products of conception, the Molar products. And she could have a gestational trophoblastic neoplastic lesions, which could have spread to the lungs. That's all.
Okay, so how do you end it?
Thank you very much for giving me this time to answer the question.
No, just say thank you very much for your time. That's your time. You earned that time. Okay. So yeah, I'm very much impressed. Like you're giving part to examination, but this the way, the perspective you've kept for this answer, even I had not thought in that way. And I'm quite impressed with how you've answered, like each thing you've connected and then you've answered the risk. So that's like well done. Okay. So though you were like, I think probably this is the first time you're speaking, and that's why you were not very fluent. But apart from that, the knowledge that you had, okay, the way you presented this answer, it was very nice. I'm very impressed.
Thank you.
Okay,
It
Tingli, well
is
done.
my first one. It is my first time.
Yeah, like how you correlated like each thing when you initially started. I didn't think like you would answer, like you would correlate each and every point, and then you answer, like it was very nice. Even I had not kept the answer of this very question in that much of detail, because there are other questions also in this, and all the 4 questions you have to do in 10 minutes. But the way you've answered this question, I was very much impressed, Tingli. Well done. Okay.
Thank you. Thank you, ma'am.
So who do we have next, Mariam?
Yes, ma'am.
Ready?
Yes, ma'am.
So introduce yourself.
Hello, I'm Dr. Mariam, one of the exam candidates. I have read the scenario. I am ready for structured discussion.
Okay, so what is the differential diagnosis now, and how will you reach the final diagnosis?
So as from the clinical scenario I have read, I will keep differential diagnosis. The first possibility of it could be written products of conception, and second, it can be a ectopic that might have been missed, and also molar pregnancy, and it could be a heterotopic pregnancy that is a intrauterine plus a ectopic, and to come to a diagnosis. I would like to go through a detailed history of the patient, in which I would exclude the possible causes. Like I would like to go in detail whether she had any dizziness, syncopal attack, any acute pain, anything. I would like to inquire. And also, I would like to check if she has passed any of the cycles, and if she has any symptoms of like a passage of the cycles or excessive bleeding and passage of clots, and also any dyspnea or any other symptoms related to molar pregnancy. Then um, and further thing I would like to investigate her. I would like to check as it is urine pregnancy test is positive. I would like to do the baseline beta HCG, and the beta HCG might have to be repeated depending upon the baseline value. And I would like to go further with the ultrasound, and depending upon the reports, I would like to go further. And also, I would like to do the baseline test, like because she's having bleeding based CBC, LFT, RFT if needed, and I might have to involve my consultant, and I might have to, because she's a case of idiopathic thrombocytopenic purpura, I might have to involve the hematologist as well in managing this patient.
Hmm.
Uh,
So Monica, Mariam, are you done?
yes, ma'am. I don't have further. I
Okay.
cannot think.
Yes.
Thank you.
So
Thank you
yeah,
for
yeah,
your time.
you did nice. Okay, you did nice. You said the differential diagnosis. You went with how to reach the final diagnosis. They have not asked the question of management over here. Okay. So you say you are also going for the management part, and what is your differential diagnosis, and how will you reach for the final diagnosis? Maybe because I told you to give, I only gave you this station, but because like the history was already taken earlier, right? So in exam,
Yes.
all the 4 questions will be for you. So you will probably not be repeating there, as this was a very short thing to answer for you. Maybe that's why you kept on including things. And in exam, no one will remind you, like introduce yourself, say thank you. Okay, that has to come
Oh,
from you spontaneously.
oh,
Okay.
okay. Okay.
Yeah. Okay, nice.
Okay.
Very good.
Okay.
So
Thank you
next
for your
one,
time.
the last one we have. Okay. So do we have O's there? Or
Hello?
he was angry that he didn't get the first one? Okay, he's still there. So this is your
Yeah,
question.
they've said almost everything. But let's.
Yeah, I wanted to give you a little longer one because she was from part 2 student. So I didn't want her to have this a very long thing question for her. So I again have to tell all the 4 candidates to introduce themselves and say thank you at the end. You've not introduced yourself.
Okay, I'm Dr. Ose, one of the exam candidates, and I'm ready for this structured discussion.
Yeah, I've gone through the instructions and I'm ready for structured discussion. Okay.
Yeah, I've gone through the instructions,
So
and I'm ready for the
the
structured
beta,
discussion.
yeah. So the beta HCG of this patient is 56,000. Platelets are 150,000. Scan shows retained product with cystic lesions. What is your diagnosis? Explain further management.
Okay. For this case, I would counsel the patient as regarding the results in the simplest of manner. The beta HCG is remarkably high, and the platelets within the normal range. I would also the ultrasound has already showed products with actually cystic lesions. I'll be thinking of a complete molar pregnancy, but because of the levels of the beta HCG, I might be thinking of also a gestational trophoblastic neoplasia, as it were. Well, this patient is actually also has idiopathic thrombocytopenic purpura. I'm also going to manage her together with that. I would counsel her that she has already actually been counseled to actually register in a gestational trophoblastic disease. I'm also from the history. I'm also going to get if she has any other risk factors, and also other if there's any possible with other ultrasound and other investigations to know if other organs are actually affected, because our management plan is going to be dependent on that. I would also try and stage her using the FIGO staging to know which management is actually going to be used, and if there may be need for any chemotherapy, as in a complete, about 13 to 16% of may need additional chemotherapy. I will also counsel her on the need, if most likely if we are going to use a single agent with either methotrexate or folinic acid, or multiple agent, the MRCOG regimen. If she has not been registered, I'll tell her about where the nearest gestational trophoblastic neoplasia center is to her. There are three in London, Dundee, and Sheffield. Also, with a blood group, I'm going to know if her blood group is ratio negative, offer anti-D. Now, for the management of this patient itself, since I've just still having some bleeding, and if we're thinking of maybe a suction evacuation to know actually before sending for histology. And she's also having idiopathic thrombocytopenic purpura, and in ITP is actually present in 3% of cases. However, we usually avoid any traumatic procedures, as it were. And if you are going to give her any pain relief, we're going to actually look at the platelet count if it's greater than 80. This is 150 here. Epidural can actually be administered to her. Regional is not actually contraindicated because she's also idiopathic thrombocytopenic purpura. I'm also going to monitor her platelets level, which is if it's less than 20, I would treat. If it's less than 50 with symptoms, I would actually and still also treat. I might offer her steroids and immunoglobulins as it were. She has already been offered platelets, and the platelets is normal. So actual monitoring is going to be done. For this patient who has actually had molar pregnancy, I also counsel her on the risk of a recurrent molar pregnancy, and also need for follow up as it were. Other risk factors including metastasis to the brain, as also using the FIGO criteria will also be monitored. I also tell her that this gestational trophoblastic neoplasia could result in 1 in 50,000 cases, as it were. So I also tell her to continue her follow up, as it were. Then I would also tell her the possibility of a choriocarcinoma, which could also occur in 1 in 50,000 of cases. I will send the samples that taken to histology, and also based on histological examination to see if there's actually proliferation of trophoblasts, extensive hydropic changes, or presence of actually villi or fetal tissue. I will also counsel her together. Is there any other thing? Let me just see. I will also counsel her on give her appropriate contraceptive pills. But before that, if there's any complication, I also tell her the complications of the procedure, because suction evacuation as well could actually have this risk, either bleeding, or if there's any perforation in any part of during the procedure. I will also debrief her and fill an incident report, and also exercise my professional duty of candor by telling her how the whole process went on honestly. Then thank you very much. I don't know what to say.
Okay, Oz, you're very fluent, but one advice, like if you can, like little bit slow down. Have you like practice station, like keeping on timer? Probably you finish everything early. You have said all the details, well done, but sometimes it's very difficult, to understand like where you are going because you are very fast.
Okay. Thank you.
Have you like practiced keeping timer, like 10 minutes timer, and have you practiced that way?
Yeah, a couple of times. Yeah, right.
So do you finish it early?
Sometimes early, sometimes after 10 minutes.
So
Yeah, I know I talk fast,
yeah,
so
you
I'll
have
try and
like,
reduce my speed. Yeah.
yeah, because you have said all the details, and that also like right before time. Okay, so the thing is, what you are speaking is correct, but it should be like the examiner should be able to understand. I was able to understand, but sometimes I would like just lose you where you are going. Okay, so one advice for
Okay.
you for this, your applied clinical knowledge on this part was bang on. You have said of ITP, but epidural, why do we need to give epidural in this case? So just a merry suction evacuation. Okay, so don't like keep unnecessary, like if it's 50,000, if it's 20,000, don't give those unnecessary informations. Okay.
Okay.
Apart from that, you said like very well. I was very much impressed. Like you just finished your exam in January, and here in just results came out in Feb, and in March of 18th, you are like so good with your part 3 structured discussion. That's quite amazing. Okay, because in my time, like what this structured discussion is took me some time to understand, because we had to change our role from role player to SD. It was difficult. Okay, so like that's hats off to you. You've done so well. Okay, just my advice would be to try to be a little more I wouldn't say very slow, but try to be clear. Okay, you are whenever you're speaking the sentence, try to speak like the complete sentence, because you are trying to speed up so fast that it would sound like you are just speeding up. Okay,
Okay, thank you very
so
much.
whatever information you are giving, yeah, so whatever information you are giving, I should get that properly, right? Okay,
Yes, ma'am.
so nice. like all the four, like it was very nice. I didn't expect like you guys would do so well. So I don't think I have to repeat it anything, but just for the sake of those who didn't participate actively. So in structured discussion, this should be your introduction. Okay, no one will tell you introduce yourself, say thank you to me. This should come spontaneously. But unfortunately, for all the I think all remaining three candidates, I had to say introduction and say thank you. And this Monica, I had to tell to say thank you at the end. Okay, so let this thing come spontaneously. So hello, I'm Maryada, one of the exam candidates. I read the instructions and I'm ready for structured discussion. So I don't say doctor usually, but with us SPT, we say like, hello, I'm Dr. Malla, or hello, I'm Dr. Oz. Okay, but here we don't usually keep it. But even if you say, it's like no hard and fast. Okay, something that is not like, if you say I'm Dr. Oz, that's not going to make you fail, but it's better you just say, hello, I'm Dr. Maryada, one of the exam candidates. I've read the instruction and I'm ready for structured discussion, because here you are with the examiner. Okay, but even if you say Dr. No harm. So initial assessment means, already said, we say we'll be asking the history, will be all this history we've already discussed before, like Dr. Manikam has beautifully asked everything, every point. And then we also do the examination that we have to say in presence of a chaperone. Okay, and then we send the investigation that will complete the initial assessment. Okay, so the risk to the patient thingy, she beautifully explained each and every risk of the patient, but I'm afraid that much time won't be given to you. So the risk in the patient is, one is that she had a failed medical management. Second, she's having a persistent vaginal bleeding. She has ITP, which itself is a risk to her of having a hemorrhage. Okay. So coming to the differential diagnosis and how will you reach the final diagnosis? So differential diagnosis means, again, she is UPT positive, means it's a new onset of pregnancy, or she had a previous failed management. It could be a threatened miscarriage. This could be a molar pregnancy or ectopic or some local cause of cervical bleeding or bleeding because of ITP. How do we make a diagnosis? For making a correct diagnosis, to see the platelet counts and her overall status, a complete blood count, I do a serum beta HCG and a transvaginal scan urgently. And then the last question, where the beta HCG is 56,000 and platelets are 150,000. USC has written products with cystic lesions. So your diagnosis will be molar pregnancy. Now, how will you manage? This patient needs to be admitted. She will be under the multidisciplinary team approach, which will comprise of consultant, hematologist, anesthetist, specialist, nurse. So this thing you should mention, okay, the MDT. And you will counsel the patient about the diagnosis in an empathetic manner. You have to be, it's a BBN, right? You will send a baseline test, and then the treatment of choice in this case will be suction evacuation. You said about the management beautifully, Jose, but you take it as pre-op, operative, and post-operative so that you do not miss any point in that, okay? And you get extra marks. Pre-operatively, I would like to, during operation, post-operatively, I would, so then it gives a good impression to the examiner, okay? So pre-operatively, I would like to take an informed consent from the patient, would like to arrange a blood products and platelet concentration because she has ITP. I'd like to do an anesthesia assessment. I would avoid prolonged cervical preparation because there's a risk of embolization, but a quick, short cervical preparation just before the procedure can be performed, okay? So this I would like to keep first on the list to show this point you should not miss. It is the safety thing, okay? So this this operation should be first on the list. I do the WHO safety checklist. This case will be performed by my consultant, okay, under the scan guidance. And unless and until there is a significant hemorrhage, oxytocin will not be used. We'll send the histopathology with correct labeling of the samples obtained, and it will inform the hematologist if there's any high risk of bleeding or she may bleed, okay? And post-operatively, we'll be monitoring her vitals, we'll be doing her input-output charting, we'll watch for pervaginal bleeding. As if she's anti-RH negative, we'll give her NTD injection, we'll do the VT risk assessment, we'll register in GTD screening center, we'll connect her with the contraception clinic for barrier method, we will avoid IUCDs, counsel about the red flag signs that shows the persistence of GTD on discharge, like persistent vaginal bleeding, dyspnea, abdominal pain, neurological signs and symptoms, give her the hospital contact number and counsel about the recurrence, which is 1%. I'd want the patient to follow up with beta HCG, returns normal within 56 days of evacuation, follow up for 6 months from evacuation. But if it does not return normal within 56 days of evacuation, I'd want her to follow up for 6 months from normalization of beta HCG. As she has ITP, I would like her to have a hematologist review. I would counsel her and keep her in support group. I would also provide her with information leaflet. So these are the conclusion points you need to include. Okay, Jose? And I hope everyone else is clear. And at the end, you say, thank you very much for your time. And then you end the station. See if there's like how much time is remaining. Okay. And that way you have to sum up your thing. Okay. Am I clear, guys?
Yeah, Clive.
Okay, so here we come to the end of the session. So I was saying about the gifts that we have. So the first 5 people who will enroll in this booster course, okay, we have gift for them, a very exciting and unexpected one, gift for them. And those who are for part 2, the first 30 people who will enroll in this progressive course, we have exciting gifts for them as well. You can copy this contact number and then contact with the backend team, or you can like even in the WhatsApp or Telegram, wherever you are, you can ask this. Okay, so I hope this session has been very useful to you. Thank you very much for your time. It's like ending a structured discussion, okay, this webinar also. So if there's any question, you guys can ask me. I'm available in WhatsApp. Thank you, Nigat. Thank you so much.
Thank you, ma'am.
Thank you, Mariam. Thank you.
Thank you very much.
Tinili. Yeah. Thank you, Oze, and thank you, Dr. Manikam.
Thank you, ma'am.
Okay, so if there's anything, you can just, okay, I'm available in WhatsApp, I'm available in Telegram or the backend team. You can also ask Dr. Zev. She's also there, okay? Yeah. So, okay, so I'll take a leave now. Okay, have a nice day ahead. Bye.
Thank you.